This conference will now be recorded.
Okay, today's topic is dengue fever. I think we have already done this topic previously. Is it? Isn't it?
No, sir.
CR? అవ్వలేదా
No,
మీకు
sir.
dengue? Okay, right. Fine,
Let's say.
fine. So dengue virus belongs to Flaviviridae family. Okay. It consists of M protein, the shell wall, the cell wall. It is not actually a cell, but a protein cell. So it is made up of protein and a capsid inside the nucleocapsid. Means the nucleic acid is the genomic, this RNA, and the surrounding thing is called as capsid protein. Okay, this is a single stranded RNA virus, member of Flaviviridae family. Actually, this coronavirus also is a single stranded RNA virus. There are selected flavivirus. They are tick-borne encephalitis virus and Bernstein virus, Murray Valley encephalitis virus, Japanese encephalitis virus, St. Louis encephalitis virus, and dengue virus from 1, 2, 3, and 4. Total 4 species of viruses are there, and yellow fever virus. All belong to this Flaviviridae family only. Dengue virus, there are 4 serotypes: 1, 2, 3, and 4. All cause full spectrum of disease. Infection once occurs, it confers lifelong serotype specific immunity. Means if a person gets infected with dengue 1, he will be immune for his lifetime for dengue 1, but he is not immune for dengue 2, 3, 4. There is no cross immunity actually, or at least short term cross immunity where for 2-3 months may be there, but not to other species. So if a person gets infected with one species, he will be immune for that only. Human carry 4 infections, can have 4 infections in a lifetime. Means 4 serotypes, 4 infections. That's all. Genetic variations within the serotype. So within the serotype, there are some genetic variation which could be more virulent. Like, one second. Uh, so some genetic variants thought to be more virulent. Like our coronavirus, initially it seemed to be more virulent. Now the virulence would have come down. Dengue viruses causes an acute febrile illness called dengue. So how the transmission of dengue virus occurs? So the mosquitoes, which are usually daytime biting mosquitoes, when the mosquito bites, first the virus enters the body and causes viremia, febrile viremia boy with dengue virus infection. What happens? 8 to 12 days later, that is called as extrinsic incubation period within the mosquito. The dengue infected mosquito then bites another person, that is a girl or boy, then it transmits. Okay, transmits the dengue virus to her. Girl can pass this dengue virus to another mosquito if bitten while she is viremic. Okay, that is in the extrinsic incubation period. So you all know this breeding areas and transmission. Aedes aegypti immature stages are typically found in waterlogged habitats associated with human habitation. Okay, they lay eggs in artificial water holding containers. These tires or these open pots or these plant pots. Okay, all this, and occasionally bromeliads and tree holes. Primarily feeds from dawn to dusk. They usually from morning to evening they will feed. Rest in the dark areas and bite in indoors, indoor biters. So most female Aedes aegypti mosquitoes spend their lifetime in and around the houses, where they emerge as adults, meaning people rather than mosquitoes rapidly move the virus within and between the communities. So you may see mainly within the migrant workers, you can see this dengue virus infection, and in some poor sanitation areas where water logging is there. Then that too after rains, if you see after rains, we will see flare up in dengue cases. Okay. What are the other routes of transmission? Evidence of transmission of dengue fever through recipients of donor organs. If donor organs they have received, okay, then bone marrow transplant and renal transplant, you can get the infection. Evidence of transmission of dengue through recipients of blood products has been documented. 7 reports of transmission from after occupational exposure in the healthcare setting is also documented. Dengue virus can be transmitted from mother to fetus in utero or to the neonate population at parturition. That is, vertical transmission is also known to occur. Clinical course of dengue. It is a systemic disease and dynamic disease. Okay, it nothing related to platelets. This so many says that platelet count comes down, then he will bleed and he will die. It is not like that. Okay, platelets are due to this autoimmune reaction from this dengue virus. Similar antibodies which attacks the virus as well as platelet receptors, they will be produced and they will bind the platelets and they may destroy the platelet. Dengue is not a platelet count disease. Okay, it is a systemic disease. Beyond platelets, so many other things are there. You should know that. Otherwise, it will be very dangerous. Just looking at the platelet count is not only the disease of dengue. Okay. What is the clinical course? Incubation period. Once it bites, incubation period will be there for around 3 to 8 days. Then viremia starts, that is the febrile phase, with headache, nausea, myalgia, body ache, and rash. This is called as febrile phase, followed by the critical phase, which may last up to 48 hours. That is, some see here 3.5 days to around 6 days, 2 to 2.5 days it may last. That is critical phase. Majority of the children require ICU support during this critical phase. Once they are out of critical phase, they enter the recovery phase. Some may not enter the recovery phase, which may have they may have downhill course in the critical phase. Means they may not be able to recover. From here only they may go downhill course and they may succumb and die also sometimes. So you see, after the incubation period, the illness begins abruptly, characterized by 3 phases: febrile phase, critical phase. Once the fever stops, then critical phase starts. That you must remember. This star mark is defined as critical phase, defined as when body temperature drops to less than 38 degrees centigrade and remain below this level, then the critical phase starts. Recovery phase commences when plasma leakage resolves and it re-enters into the capillaries. Mainly dengue, it will leads to capillary damage and will lead to leakage of all the fluid from intravascular compartment into interstitial as well as extracellular compartments. That is why we have all this edema with into the lungs, like pleural effusion, pericardial effusion, all effusion, ascites, all can be there. But the intravascular compartment will be depleted and hematocrit will be raised. Okay, so child may go into shock and renal failure and all multi-organ damage can occur. So here see, day 0 of illness in the febrile phase, temperature will be there. Once defervescence starts, child will enter to critical phase. they will have subnormal temperature, that is less than 38 degrees centigrade. And sometimes some children may have saddleback, that is biphasic fever. Even in dengue, even in now COVID also, some people are having febrile phase followed by defervescence. Then again, the biphasic fever is there in COVID also for some persons. Okay, this is saddleback picture or biphasic fever. Then recovery. Here, if you see the virology and viremia, febrile phase is corresponding to viremia. Once the virus enters, it starts having viremia and peaks. The febrile phase and viremia matches. Then gradually, once the viremia is coming down, our antibody IgM and IgG antibody starts rising up. Means the patient is recovering from the infection. If you see the same time laboratory changes, what is happening to the laboratory changes at this point of time? If you see the hematocrit is very important. Once in the febrile phase, the hematocrit is almost stable. There is not much changes in the hematocrit. Once the child enters the critical phase, means leaky phase, you call it as leaky phase because all the fluid from the intravascular compartment due to endothelitis and will be leaking into the interstitial and extracellular compartments. So hematocrit is what is happening to hematocrit here? It is rising, peaking. Okay, you should be giving adequate fluids to maintain intravascular volume, to maintain blood pressure and organ perfusion. See here, one after the critical phase, again the hematocrit is gradually dropping down and again it is normalizing. Okay, what is happening to WBC? WBC here, it is initially stable, then started dropping down. Mainly lymphopenia occurs during the febrile phase, then down, it is troughs during critical phase, then gradually improving and recovering. You see WBC count. Here platelet count, it is very much stable till febrile phase and then suddenly drops in the critical phase, leaky phase. If you see here it is all in the lower levels only. Rising hematocrit is more dangerous than dropping platelet count. Platelet count may drop up to less than 20,000 also, but child may not have any bleeding signs or symptoms. We should be more worried when the hematocrit is rising more than 20% from the baseline, then it is very dangerous. So he may land up in shock and other hemocoagulation abnormalities, then they may bleed. Okay, or they may have ischemic changes also. So what will happen here? If we should maintain hydration, if you don't give proper hydration, dehydration may occur during febrile phase. Like any other viral fever, we always advise no hydration. So if you don't give that properly, the child may go into dehydration. And in critical phase, that is shock, because leaking from the intravascular compartment leads to shock, and bleeding also can occur during this phase. Here see capillary permeability is increasing, means leaking is increasing in the critical phase, then again dropping down. Here recovery means all the endothelitis and all will improve, then whatever is leaked outside will gradually come into intravascular compartment and then goes out as urine. Understood? So febrile phase usually lasts for 2 to 7 days, but usually 72 hours it will last, 72 hours to 96 hours, that is 3 to 4 days practically if you say, but rarely it may last up to 7 days also. High temperature may be modified by antipyretics. Okay, we may not get high temperature because child may already would have taken some antipyretics. Common symptoms like myalgia, body aches, headache and retroorbital pain. If you take specific sign for this, is one of the thing is retroorbital pain, okay, behind the eyes, and aches, rashes you may get blanchable rash all over the body. Difficult to differentiate dengue from other febrile viral illnesses. Okay, normal CBC in first 1 to 2 days. Complete blood counts will be normal in the first 2 to 3 days of fever. Once this phase crosses only, you will see all the changes like drop in WBC count, at lymphopenia specifically, and drop in the platelet count. All you will be seen after 48 to 72 hours only. Children may have nausea and vomiting may be prominent in this febrile phase. Okay, the transition from febrile phase to critical phase, usually after 4 to 7 days of the illness, this transition of febrile phase to critical phase occurs. Could be as early as 3 days also. I told you, 3 to 4 days also. Coincides with deference, means fever will be subsiding, then critical phase will be starting. Development of warning signs. Identify dengue patients already in shock or at risk of developing shock with these warning signs like severe abdominal pain, persistent vomiting, mucosal bleeding, lethargy, restlessness, and enlargement of liver more than 2 centimeter, clinical fluid accumulation, that is ascites or pleural effusion, and all these things. And laboratory wise, you may have leukopenia, rapid decrease in platelet count, and rising hematocrit. Understood? What happens during the critical phase? During critical phase, the vascular permeability is increasing, so there will be significant plasma leakage. Okay, how long this plasma leakage occurs is 24 to 48 hours, and there after this there will maybe development of warning signs and deterioration of patient condition may occur. Okay, without treatment, what can happen? There can be death also in this phase. We should treat properly. Shock occurs when critical volume of plasma is lost through leakage. Shock is often preceded by warning signs. Body temperature may be subnormal when shock occurs. Okay, the total WBC count may increase. Instead of leukopenia, total WBC count may increase in patients with severe bleeding, that is stress response. Understood? So do all dengue patients enter critical phase? No, not all patients will experience the critical phase. Few may not experience this critical phase. After defervescence, they may start recovering also. It depends upon how our body reacting to the, how our immune system reacting to the virus. Similar to our COVID virus now, how our body is reacting, that is more important. Some may be asymptomatic completely, some may be having mild symptoms, some may have entered into critical phase. Even dengue is also like a menace, like COVID only, but the transmission, this is due to transmission is through mosquitoes, that is through our person to person transmission. That is why this COVID is causing so much menace. Clinical course of the patient without significantly increased vascular permeability. Fever subsides and then general condition improves. The appetite then recovers. Okay. If you see fever subsides, general condition improves, then appetite will come back. That is a sign of recovery. Many have leukopenia for long days. Mild to moderate thrombocytopenia can be there. Okay. Okay. Recovery phase. What happens in recovery phase is vascular permeability stops and it reverts to normal, means gradual reabsorption of extravascular fluid in the next 48 to 72 hours. What are the clues to progression from clinical phase to recovery phase? Clinical means that child is recovering from this critical illness, improvement in the general well-being of the patient, and stable hemodynamic status. Diuresis means passing urine, plenty of urine, and means all the accumulated edema fluid is now coming back to the intravascular compartment. No, that is going to kidneys and filtering out. That is diuresis. Biphasic fever can occur. I told you, previously. Some may have going to defervescence, then again have 2 to 3 days fever. May have bradycardia. Bradycardia is also sign of recovery. Means relative bradycardia, not completely bradycardia. It may be around 60, 55 like that. Okay. Itching is a sign of recovery. When the child starts, after the blanchable rash decreases, child will start itching, then that is a sign of recovery. Okay, bradycardia and itching. Islands of white in a sea of red, means here if you see these white spots in a sea of blanchable rash, this is the sign of recovery. Understood? This is full of rash, in this white islands are there if you see. What are the laboratory clues? Hematocrit. Okay, PCV. It gets stabilizes after some time. Hematocrit may lower due to dilutional effect of reabsorbed fluid. Understood? Hematocrit may drop. WBC usually starts to rise soon after defervescence. Thrombocytopenia persists longer than leukopenia. Understood? Thrombocytopenia may recover. So that's why we should not ask the patient to stay for long duration in hospital. Once all the hematocrit stabilized, hemodynamically stable, and WBC have recovered, and all these signs have recovery signs have occurred and child is eating well, we can always ask them to come back to repeat a platelet count after 2-3 days. We should not ask them until thrombocytopenia improved, that is more than 1 lakh or 1.5 lakh. We should not ask them to stay in the hospital. We can always send them. Don't wait for discharge for only thrombocytopenia. Understood? When to consider severe dengue? Severe dengue means is defined as with one or more of these following. Severe plasma leakage means completely from the intravascular compartment fluid is coming out. Severe bleeding, severe organ impairment. This is called a severe dengue. It definitely requires treatment within ICU, tertiary ICU. Severe manifestation of dengue are related to severe plasma leakage, reduced organ perfusion and tissue hypoxia, organ impairment. Understood? When to consider severe dengue? Severe plasma leakage leading to hypovolemic shock, having respiratory distress due to fluid accumulation, either pleural effusion or ascites. Severe bleeding, patients remaining in shock despite IV fluids and hematocrit is decreasing. Okay, means with the internal bleeding is happening in this body. Bleeding can be occurred and not recognized in a timely manner. Important to do frequent vital signs and monitor hematocrit. Bleeding usually occurs in the GI tract and rarely in the brain. Severe bleeding exacerbates shock. Severe bleeding has been observed in adults who had no or only mild plasma leakage. Severe organ impairment, consequences of hypovolemic shock. Once hypovolemic shock occurs, other organ damage can occur, no, multi-organ dysfunction. This is alanine transaminase, aspartate aminotransferase. Okay, more than 1000 IU per liter means liver is affected. Impaired consciousness, impaired cardiac function, raised cardiac enzymes with reduced left ventricular functions. Liver enzymes are frequently elevated during the critical and recovery phases. Understood? So we should not think that recovery phase hasn't started. Liver enzymes are frequently elevated during critical and recovery phases. It may take longer time also. Severe impairment of organs such as liver, kidneys, brain has been observed in patients with only mild or no plasma leakage or after critical phases of dengue. So conditions that mimic this febrile phase of dengue are viral infections like influenza, measles, rubella, chikungunya, West Nile virus, enterovirus, and other viral hemorrhagic fevers, infectious mononucleosis, and acute HIV seroconversion illness. Bacterial infections like leptospirosis, typhoid, rickettsial infections. Parasitic infestations like infections like malaria. Febrile illness with a rash like measles, rubella, infectious mononucleosis, enteroviruses, chikungunya, West Nile virus, scarlet fever, meningococcal infection, leptospirosis, typhoid, rickettsial, syphilis, acute HIV seroconversion, autoimmune diseases, adverse drug reactions. Diarrheal diseases like rotavirus, salmonellosis, and other enteric infections are the differential diagnosis during the febrile phase of dengue. And acute abdomen, critical phase may manifest with some acute abdomen also. So acute appendicitis, cholecystitis, perforated abdomen means viscous in the abdomen, diabetic ketoacidosis are the differential diagnosis for this acute abdomen. Acidotic breathing and respiratory distress, DKA, lactic acidosis, renal failure, and ARDS. Infections like sepsis, septic shock, acute gastroenteritis, leptospirosis, typhoid, typhus, malaria, viral hepatitis. Autoimmune disease like SLE, idiopathic thrombocytopenic purpura, TTP, thrombotic thrombocytopenic purpura, systemic vasculitis. Malignancies like acute leukemia, lymphoma, and other malignancies. Others like liver cirrhosis with portal hypertension and adverse drug reaction. So these all mimic the dengue in the critical phase of illness. Understood? What clinical examination you should do? General assessment like mental status means circulation to the brain is good or not. Hydration status, how is hydration? Hemodynamic status, very important. Clinical evidence of warning signs like bleeding manifestation, mucosal bleeding, abdominal tenderness, liver enlargement, clinical fluid accumulation like pleural effusion and ascites. Other important signs like rash, tachypnea, acidotic breathing indicate shock. Tourniquet test, repeat if negative or if there is no bleeding manifestation. Okay, tourniquet test is nothing but If you increase the pressure by applying a tourniquet in the forearm, you may see spots, more than 20 spots in a 1 square centimeter area, then it is considered as positive. Hemodynamic assessment, clinical parameters. What you will monitor for consciousness level means organ perfusion to the brain, capillary perfusion refill time, extremities, and peripheral pulse volume, that is peripheral circulation, heart rate, pulse pressure, and blood pressure for cardiac output, indicates cardiac output, respiratory rate, respiratory compensation for tissue hypoxia, urine output, organ perfusion to the kidney. Understood? You should monitor for all these organ. These are the markers of organ functions. Okay. Consciousness level, capillary refill, extremities, peripheral pulse volume, heart rate, pulse pressure, blood pressure, respiratory rate, and urine output. See, if you see here, pallor, very pale. This is better with rash. Here it is pale. Magic touch. This is 5-in-1 maneuver. If you touch, you will see the color, capillary refill, temperature of the extremities, and pulse volume and pulse rate. You can see that is called as magic touch. So that is 5-in-1 maneuver. Delayed capillary refill time. The blood pressure was normal at this time. Okay, here there is delayed capillary refill, but blood pressure is normal at this time. Hemodynamic status assessment. Stable circulation means consciousness. Child is very much conscious, clear, and lucid. This is indicates normal brain function, perfusion. Capillary refill time, brisk, that is immediately refilling, less than 2 seconds. Extremities, color is pink and temperature is warm. Peripheral pulse, good volume. It indicates normal peripheral perfusion. Heart rate normal, pulse pressure normal, BP normal means normal cardiac output. Respiratory rate within normal range for age is no respiratory compensation for acidosis. Urine output normal means normal kidney perfusion. Here it is called a stable child, stable circulation. Understood? So here hemodynamic changes in compensated shake. What will happen initially? There is normal or elevated systolic pressure only, blood pressure. Rising diastolic pressure. Narrowing of pulse pressure occurs. Reduced peripheral perfusion. Quiet tachypnea can occur. And lucid consciousness level with then decreased urine output can occur gradually. Okay. Heart rate is initially increasing, if you see here. And blood pressure is maintained initially, then dropping down. Here, if you see in compensate shock, what will happen? Consciousness is better, normal brain function, but reduced peripheral perfusion by prolonged capillary refill time, cool peripheries, weak or thready peripheral pulse. Reduced cardiac output by tachycardia for age, normal systolic pressure, rising diastolic pressure, narrowing pulse pressure, postural hypotension, and quiet tachypnea for tissue acidosis. Reduced kidney perfusion, reducing trend. Okay, urine output may reduce. See, hypotensive shock, what is happening? Till certain limit, heart rate has increased and blood pressure is maintaining. But after certain limit, what is happening? Blood pressure is dropping down. Values are dropping down. Systolic, diastolic, it is coming down, coming down. So increasing tachycardia means heart rate is increasing. Feeble or absent pulses, peripheral pulses, systolic and diastolic pressure disappear suddenly. Reduced peripheral perfusion, that is very cold extremities, mottled peripheral cyanosis, very prolonged capillary refill time. Kussmaul's breathing means acidotic breathing. Decreased level of consciousness, that is brain perfusion is coming down. Oliguria and anuria means kidneys perfusion is also coming down. Understood? So key clinical signs of deterioration are like changes in mental status, restless, confused, extremely lethargic, may have seizures also, agitation, alternating with drowsiness. Infants and young children failure to recognize parents, focus or make eye contact, listen to parents, something is wrong with my child. Okay. Imminent total cortical respiratory collapse can occur. What is considered adequate urine output is a patient with dengue should pass at least 0.5 ml per kg per hour urine. Okay, that is called as normal, at least normal urine output. What happens in hypotensive shock? Consciousness will come down, restless, combative. Here, reduced peripheral perfusion, as we discussed, reduced cardiac output with severe tachycardia or bradycardia in late shock, hypotension, unrecordable BP, narrow pulse pressure, Kussmaul breathing, severe tissue acidosis, no kidney perfusion, anuria, complete absent urine. Understood? So what happens here? Pearls and pitfalls in dengue shock is dengue shock presents as a physiologic time continuum. Then it is a continuous process. We should break it. Compensated shock in the early stage, that is normal or elevated blood pressure, become decompensated shock in the late stages, that is hypotension and unrecordable blood pressure. Child is stable in the initial hours, had warning signs. After hours, child enter into compensated shock. After few hours, child enter into hypotensive shock. And within few minutes after from the hypotensive shock, child entered into cardiac arrest. Understood? So identification and treatment of early shock will improve the clinical outcome. If you stop the child from entering all these phases at the warning sign stage itself, you can definitely bring out the child. So early treatment is very important in dengue. Identification and treatment of early shock will improve your clinical outcome. Delayed treatment leads to clinical course. Already if child is entering hypotensive shock, within minutes can have cardiac arrest. So we should not allow the child to go into hypotensive shock at all. Severe bleeding will exacerbate the shock state, and if unrecognized will lead to refractory and irreversible shock with a very poor outcome. Okay, what is the pitfall? Why is it easy to miss dengue shock? Even in severe shock state, patient appears deceptively normal or stable with a lucid conscious level. Okay, until late stages, the child consciousness will not be damaged, or child consciousness level will be normal until late stages. That is why we may miss dengue shock. A careful physical examination is critical to recognizing a patient in shock before the stage of cardiovascular collapse. So before this stage only we should recognize it. Investigations. We should always do complete blood count with special emphasis on hematocrit, that is PCV. Okay, PCV, white cell count and platelet cell count are special importance. The dengue specific test, like for confirmation, initially we can do dengue NS1 antigen, IgM rapid test or nucleic acid detection. Not necessary for the acute management of patients, but valuable in unusual manifestations, suspected dengue deaths in the area, or for patients who progress rapidly from mild to severe dengue. Other blood tests like liver function tests, serum electrolytes, urea and creatinine for kidney functions, and glucose should be considered in patient with the risk factors and severe disease. Laboratory warning signs. Leukopenia occurs 24 hours before rapid decrease in platelet count. Not predictive of plasma leakage. Good indicator that patient could have dengue. Understood? Rapid decrease in platelet count plus rising hematocrit that indicate occur shortly before or at effervescence, may precede changes in BP and pulse pressure, indicate an increase in vascular permeability. Understood? By laboratory tests also you can identify what is happening with the child. Rapid decrease in platelet count with a rising hematocrit indicates child is entering into critical phase, that is increased vascular permeability. Understood? Coming to management, group A, patients who are able to drink enough to pee enough, that is child is able to take oral and passing urine well. Send home if patient meets following criteria. Intake, child is orally accepting fluids well, output passing urine well at least once in 4 to 6 hours, do not have any warning signs, he is having stable hemodynamic status, not having any coexisting condition. We can follow up him daily. Do ask them to do serial blood counts, and I tell them what are the dangerous and warning signs. If the child is not in shock but having warning signs, we should always keep them in the hospital. Okay, start with isotonic fluid therapy, 5 to 7 ml per kg per hour for 1 to 2 hours, then reassess. If improved, then you can gradually come down on fluids every 2 to 4 hourly. After clinical improvement and child is able to take orally, we need not do anything. Okay, it will improve once child start taking orally. Assessment, already we told, no magic touch. Hematocrit remains same or minimally high, then stepwise reduction in IV fluid should be done. Okay, continue to monitor patient until critical period is completed. And if there is hypotensive shock, immediately we have to give bolus, that is 20 ml per kg of isotonic saline, okay, or 20 ml per kg in child, or 15 to 20 minutes fastly we should give, then reassess. Then he improved means again 10 ml per kg per hour for 1 hour we should give. Then gradually we should reduce the fluid volume every 2 to 4 hourly, and once child taking orally we should stop fluid. After while racing, after giving bolus, if not improved, check hematocrit levels. If there is decreasing hematocrit, we should see for any overt bleeding is there from any organs. If yes, give urgent blood transfusion. If there is no bleeding, give colloid, try colloid. If there is increasing hematocrit and colloid is if you given colloid also, then we can give then later crystalloid and see for improvement. Monitoring organ function. Okay, we already told that no, initially liver for enzyme elevation, for brain mental status, how is he is not agitated and cool and calm. What are the risks of bleeding? Minor mucosal bleeding, epistaxis, gum bleeding, not uncommon. It is not uncommon to have this. Okay, what are the sites of major bleeding? GI, gastrointestinal tract is the most common site. Any form of trauma like venous chest tube insertion sites, nasogastric tube insertion may cause severe epistaxis. Why pathophysiology of thrombocytopenia? Early bone marrow suppression is one thing by the virus. Peripheral immune mediated destruction, okay, by dengue virus binding antibodies binding to dengue virus and to platelets also. Understood? I told you, no, platelets aggregate on dengue virus infected endothelium, and there is clearance by macrophages and hemophagocytosis. All this leads to decreased platelet count. Even when actively bleeding, don't transfuse platelets. It is not a disease of platelets. Understood? Emergency treatment of hemorrhagic complications. Give fresh packed RBCs. Okay. If, what is clinical response? Improve in hemodynamic status, peripheral perfusion, urine output, improving acid-base balance. When should you consider repeated blood transfusion? Further blood loss, unstable hemodynamic status, no appropriate rise in hematocrit after transfusion, then only we should consider repeating blood transfusion. Okay. Other complications, there can be excessive plasma leakage, okay, and one or more of the following should be there. Fluid overload also can occur. So one or more of the following, like excessive or too much rapid IV fluid. We should not give rapid IV fluids until the child is in hypotensive shock in case of dengue. Use of hypotonic solution may also lead to fluid overload. Transfusion of FFP, platelet concentrate, cryopreid, all can lead to fluid overload. We should consider all these things. Okay. Other issues to be managed like hypoglycemia, hyperglycemia should be addressed properly. Hypokalemia, hyperkalemia should be monitored. Hypocalcemia, metabolic acidosis, and co-infections and nosocomial infections to be vigilantly observed. Supportive care is very important during this treatment. Discharge criteria. No fever for 24 to 48 hours, improvement in clinical status, that is general well-being, good appetite, stable hemodynamic status, adequate urine output, no respiratory distress, and no organ dysfunction. Then he is fit for discharge. Increasing trend of platelet count, increasing trend, not normal platelet count, increasing trend from thrombocytopenia, stable hematocrit with oral intake and off IV fluid, rash, characteristic of dengue, who needs to be followed up. Follow up patients with organ impairment, otherwise no need to follow up. Carica papaya and these leaves no one is using, and we don't know whether actually they improve the platelet count and all. It is not a disease of platelet count, that we should remember. Okay, so dengue is not a disease of platelets. Don't prescribe carica papaya tablets and syrups and all. Proper monitoring and early detection of complications will result in better survival of the patient, survival rates of the patients, decrease complications, decrease ICU and decrease morbidity. Okay, understood? CR?
Yes, sir.
Okay, understood? Any doubts are there? You read once dengue from WHO. WHO guidelines are there. Dengue PDF. You can go through it. Okay.
Yes, sir.
What is the
Yes,
mosquito?
sir.
Name of the mosquito? Transmits this one. Dengue. Name of the mosquito.
Aedes aegypti.
Here. Aedes aegypti. Right. Okay. Take care. You can leave.